Good afternoon, everyone. We're talking about orbital diseases and sickle cell disease patients. First, I'll start with a quick introduction. Then I'll concentrate on orbital wall infarction regarding pathophysiology, clinical manifestations, imaging management, and then we'll go through some interesting, unique cases. Then we'll conclude with some take-home messages. As we all know, sickle cell disease results from the inheritance of abnormal globin genes, which causes the globin to be hydrophobic. The globin molecule will be hydrophobic because of a substitution of amino acid. This abnormal globin will get sickle-shaped and rigid in the case of hypoxia and acidosis. This will cause blockage of small capillaries in different parts of the body, which called vaso-occlusive crisis. It happens at any organ, but most commonly in the bone, more in the vertebrate and long bones. So the patient will have recurrent attacks of vaso-occlusive crises with pain with variable intensity, localized at one or more areas of the skeleton every time. The pain is believed to be caused by the increased intramedullary pressure and because of the inflammation response of the infarction within the bone marrow. This may be combined by localized tenderness, swelling, erythema on the site of the pain. Mostly during vaso-occlusive crisis, the patient will suffer of fever and leukocytosis. Although precipitating factors are described as infection, dehydration, exposure to cold, but in many cases they can present with the crisis without these precipitating factors. Sickle cell retinopathy, anterior segment ischemia, glaucoma, and angioid streaks are well recognized as ocular manifestations of sickle cell disease. On the other hand, orbital manifestations are less recognized and documented in the literature. Since 1983, only 48 cases of sickle cell disease associated orbitopathy have been reported. Yet it is important to gain awareness and attention to this problem, as it may cause permanent visual loss. It is especially important for us as the kingdom have a high prevalence of sickle cell disease, especially in the eastern and southeast regions. It was in 2011, it was estimated to be around 17% in the eastern region, which is among the highest of the Middle East and the world. The highest is in South Africa, which reach around 40%. It's important to notice that in Oman it is 5.8%, which is less than the percentage in our population, and yet most of the case series and reports comes from Oman, with only one report from Saudi Arabia. So this tells us that this entity is overlooked and under-recognized in our population. The sickle cell disease can affect the orbit either with orbital wall infarction, orbital infection, or paraosseous extramedullary hematopoiesis. We'll concentrate on orbital wall infarction. It was believed that the facial bones, because of the small or little more marrow space, that it's infrequently affected. But in the young age, the marrow has a greater space, so they are susceptible to orbital wall infarction during the youth. The bone marrow infarction, together with the occlusion of the vessels because of vessel wall necrosis, can cause subperiosteal hematoma formation. This, together with the inflammation caused by the infarction and the edema caused by the venous outflow obstruction, can cause what we call orbital compartment or compression syndrome. There will be increase in the intraorbital pressure, displacement of the globe, causing proptosis, limitation of movement and pain, and pressure on optic nerve, causing visual impairment, together with sensory nerves causing corneal hyposthesia. All patients with orbital wall infarction will present with periorbital pain and swelling. When the inflammation is severe enough, it can cause conjunctival redness and chemosis. And when orbital compression syndrome develops, patient can complain of proptosis, limited motility, corneal hyposthesia, and optic nerve dysfunction. I gathered all the data from the reported cases. The mean age of these patients are 14 years, ranging from 1.5 to 35 years. The male to female ratio is 2:1. As we said, pain and lid edema is always present in this kind of patients. Fever, as in other vaso-occlusive crises, is commonly present with leukocytosis. Some other pain crisis at other sides of the skeleton is common, 76%. Usually they present with orbital signs, and more than half of them will present with decreased visual acuity, with permanent visual loss in 2 cases reported. All of the reported cases did not have sickle cell retinopathy at presentation. The hemoglobinopathy usually present is the homozygous sickle cell disease. There is 5 cases of sickle cell hemoglobin C and sickle cell, and 1 case of sickle cell beta thalassemia. Ganish et al. In Oman showed they studied the relation of the severity of the disease itself and the severity of the orbital manifestation, and they found that there is no relation between the severity of orbital manifestation and the severity of the sickling hemoglobinopathy. Imaging is an important modality in orbital wall infarction. Bone or bone marrow scintigraphy are first used during the 80s before the MRI was popularized. It nicely shows the infarction area with the reduced uptake of the radioactive material injected, which is usually uptaken by the osteoblast. So in infarcted bone and necrotic bone, the osteoblast will not present. That's causing the decrease in uptake. Here a bone scan with decreased uptake in the orbital bone. It's a good modality, but the problem with it is that it is dependent to the timing of the study. Usually it shows the reduced uptake during the acute stage, which is the first 48 hours, and later it will show increased uptake because of the increased vascularity due to the healing process. CT scan is only important because if it is fast and it can differentiate subperiosteal hematoma from orbital abscess. Otherwise, it does not show the bone abnormalities in bone wall and orbital wall infarction, as in this case. This case had orbital wall infarction, but the CT scan does not show any change in the orbital bone, yet it shows the hematoma, subperiosteal hematoma, and the epidural hematoma. So the gold standard in orbital wall infarction is the contrast MRI. It's more sensitive and more specific. Because it's capable of delineating the ischemic changes in the marrow space, it can reliably distinguish between vascularized inflammatory tissue and fluid, and it can characterize the fluid as either abscess or hematoma. As you see in this MRI, you can see the infarction in the sphenoid wing with the subperiosteal hematoma with the ring enhancement. The same in the coronal section. And you see in the T2 images, when you compare with the other sphenoid wing, you see the intensity, abnormality, and the subperiosteal collection. You can see in this case, he had a very severe inflammation, and on MRI, you can see the abnormality in signal in the sphenoid bone together with an inflammation instead of subperiosteal collection. That shows on sagittal how it goes all the way to the apex, and you see the reduced CSF around the optic nerve, meaning that the optic nerve is compressed. This patient was started directly on intravenous steroids, and prompt resolution was noticed within weeks. So that takes us to the management. All patients with orbital wall infarction, they respond nicely to the standard vaso-occlusive crisis treatment, which includes the intravenous fluid, simple or exchange blood transfusion, and analgesics. In cases where there is optic nerve dysfunction, intravenous steroids should be started to fasten the resolution of the inflammation and relieve the pressure of the optic nerve. Surgical evacuation is only needed when you have a very large hematoma that compresses the optic nerve. Yet you have always to start the patient on broad spectrum antibiotics, especially if you are uncertain about the diagnosis, and do the microbiologic workup, including blood culture and culture from the aspirate if you aspirate. The reason of the dilemma between the infection and the orbital wall infarction is that sicklers are immunocompromised due to the auto-splenectomy they have and impaired complement activity. They are prone to infection, together with the presence of the infarct and necrotic tissue that increase the possibility of infection at this area. Both the orbital wall infarction and orbital abscess can present with fever and leukocytosis, which makes it more difficult. There is reported cases of orbital abscess formation at the site of the ischemic or necrotic bone, but there is no reports of osteomyelitis at the orbital bones complicating vaso-occlusive crisis. There is some alarming signs that makes infection more favorable is that if the fever is high grade with chills, if there is severe erythema and tenderness, and if there is persistent pain not resolving with the usual supportive therapy. Now we'll go through some interesting and unique cases. This patient is a 4-year-old boy. He's a homozygous sickle cell disease. He came with a vague history of left-sided headache and pain with rapid progression of periorbital swelling. On examination, they found that he have maxillary sinus tenderness and bilateral proptosis. The eye examination was within normal, and systemic examination was within normal, including a nasal endoscopy. So their working diagnosis was sinusitis with orbital cellulitis. But on the CT scan, they found expansion of the maxillary bone with this heterogeneous soft tissue density on both bones, with intense swelling of the maxillary bone on the MRI. And their diagnosis was extramedullary hematopoiesis. This happens because of the chronic anemia those patients have. This causes a hyperactivity in bone marrow. So in small space bone marrows, this hyperactivity causes herniation of the medulla, which causes such cases. That patient received exchange blood transfusion, and he responded well. If he does not respond to only transfusion, radiation cytotoxic agents can be used. In this case, he was not known to have sickle cell disease. She's an 11-year-old girl. She presented with fever, headache, and generalized weakness for 4 days. She had bilateral painful proptosis for 1 day associated with sudden loss of vision and parallel discharge. There was no history of nasal blockage, sinusitis, dental pain, or procedures. No history of trauma, bone pains, or frequent illness. She is the fourth of 7 children, and a 3-year-old sibling died following fever and severe anemia. She had lived in a rural area with farmer parents who are genotypes not known. So in examination, she was lethargic, pale, and mildly dehydrated with tender hepatomegaly and splenomegaly. The visual acuity was no light perception in both eyes. Both pupils were unreactive, and she had a proptosis of 23 millimeter in both eyes. There was no extraocular muscle movements at all, and the cornea in the right eye was hazy with turbid anterior chamber. And the left eye, the cornea was clear with a quiet anterior chamber. Lens was clean in both eyes, and she had a bolus excessive retinal detachment in both eyes. The IOP was 60 millimeter in both eyes. This is her B scan. It's not clear. And the CT scan shows that no other pathology within the orbit, only inflammation surrounding the eye with scleritis, and the bolus RD. And on electrophoresis and chromatography, they found that she has homozygous sickle cell disease, so they diagnosed her as orbital wall infarction with severe inflammation that caused exudative RD. They started her directly on IV steroids, IV fluid, and analgesics, and she improved directly regarding the proptosis, the chemosis, and her general health, but the visual acuity was not regained. They discharged her weeks later with tapering oral steroids, but unfortunately she was lost. This is another case where the patient was not known to have sickle cell disease. 70-year-old young man presented with 5-day history of periorbital swelling and proptosis in both eyes. He had frontal headache, transient episodes of altered sensorium with decreased interaction with relatives for 4 days. He had no history of seizures. He had history of low back, but no history of pain, fever, or bleeding from any other sides. There was no history of local trauma or insect bite, and the family history was unremarkable. He was afebrile with mild pallor and no icterus. Visual acuity was 6/6 in both eyes. There was no PD in both eyes. He had bilateral periorbital swelling with proptosis, bilateral conjunctival chemosis, and exposure keratitis in the right eye with restriction of ocular movements. On fundus exam, he had macular edema with venous engorgement, but he did not have any hemorrhages. The rest of the systemic examination was within normal. His CT scan showed subperiosteal hematoma collection, both roofs with epidural hematoma. the right side. He was his peripheral smear of the blood showed large number of sickle cells. They did chromography and found to be sickle beta thalassemia. His father was examined, found to be beta thalassemia, and his mother beta thalassemia trait, and his mother sickle cell trait. So they diagnosed him as orbital wall infarction. They started the usual supportive therapy of IV fluid, transfusion, and analgesics, and he responded well. This is the only case reported from Saudi Arabia by Professor Haibani. This is 11-year-old Saudi boy with right eye pain and swelling. What's unique about this case is that he had similar attack 3 years before, proptosis and swelling in the same eye, with diagnosed sphenoid wing infarction and subaortic collection. Was treated that time with the supportive therapy, and he responded very well. Then he presented 3 years later with the same presentation, and again he had bone marrow sphenoid wing infarction and subaortic hematoma with the you see the enhancement, the ring enhancement around it. These are the CT scan, the previous one 3 years before, and the current one, and shows that it happens in the same site. So orbital wall infarction can be recurrent in the same bone. There's another case of recurrent orbital wall infarction, but in the other eye. This patient had orbital wall infarction, the right side, with suborbital collection and masticator area collection. Then 18 months later, he developed swelling and pain in the left side with the same findings on the CT scan. What's unique about this case is that they did ultrasound guided aspiration before they started any antibiotic, and it was negative for crumb stains and cultures. So that was a proof that this collection is not an infection. Actually, it was just a hematoma because of the infarction. And then both times they responded well to conservative management with systemic antibiotic coverage. So orbital wall infarction in sicklers is an underdiagnosed diagnosis. Should be kept in mind when managing a sickler patient that have history or signs suggestive of sickle cell disease. It usually responds well to the medical management of IV fluid, blood transfusion, and analgesics. IV steroid should be started directly if there is any optic nerve function deficit, and surgical evacuation only needed if there is large hematomas compressing the optic nerve. The microbiological investigation and broad spectrum antibiotics should be always started to rule out infection. Thank you.
Thank you, Dr. Ahmed, for the interesting message today here to take home. Usually it is uncommon to have the sickle cell disease with orbital wall infarction. Since I joined, I remember since I joined the BSMMC, I saw just one case, around 8 years old boy with the unilateral orbital bone infarction. And he was having the proptosis and almost all the symptoms that Dr. Ahmed have described. He's been under the general surgeon, and they were treating him a similar way, and he was improving. So it is important to, as far as I know, that most patients, especially some ethnic group with pre-orbital cellulitis, that we have to do the blood electrophoresis or during birth to do the blood grouping and the electrophoresis to manage him as fast as we discover the disease. Anyone want to ask or have a comment? Dr.
Yes.
Hera?
Uh, yeah, the hemoglobin level should be always above less than 40%. So if they are closely followed up with hemoglobin level kept in good position, they should not, because most of the patient I reported, they had a very high hemoglobin F and A2. So that gives an idea that if he's not following up well with the hematologist, this is a big risk factor for this condition.
Hydration also, I think, hydration and excess
Yeah,
fluid and prevent infection, predisposing factor for the sickle cell crisis. It usually happen with, I think, the repeated attack of the varicose.
Most patients reported had recurrent attacks of
Recurrent
vaso-occlusive
attacks, yeah.
crisis before they present with our
Usually they are having some of them infection, fever, low immunity. So hydration, I think, will be most important in these cases.
Well, their explanation of the case is that the severe inflammation because of the autonomic infarction caused the oxidative. But yeah, part of the ascaritis caused by the inflammation. But actually, this case report was missing a lot of information, so you cannot rely on this diagnosis. But this is the only explanation for it.
Okay, thank you very much, Dr. Ahmed, again.
Thank you.
And hope you enjoy it.